Hello viewers, good day to all of you. So in this class I am just going to give some finishing touches to the upper limb and the lower limb which we have been discussing for the past couple of months. Okay. Now with respect to the surface anatomy, I am going to touch upon certain nerves and the vessels. Most importantly, I have concentrated on this lecture on the nerves and vessels of the upper limb and the lower limb. Apart from that, the skeletal structures, mainly the bony prominences like your clavicle, acromion process, coracoid process, greater tubercle of the humerus and the lesser tubercle of the humerus, and so on. We can go on, keep on enumerating with respect to the upper limb. Same way in the lower limb, your anterior, superior, anterior, inferior, posterior, superior, iliac spines, ischial tuberosity, trochanter of the femur, condyles of the tibia, tibial tuberosity, malleolar prominences, all those things can be enumerated. Now these things I will not be discussing in this class because in the introduction to the upper limb and in the introduction to the lower limb, while I was discussing about the osteology features, important salient skeletal features or salient features of the bones of the upper limb and lower limb, there itself we have discussed. So these structures which I am going to discuss in today's class is specifically on examination point of view. Okay, so we will go with the first structure. What you are able to see here is the axillary artery. Okay, so the axillary artery, how actually you will mark the axillary artery on the upper limb. So in the surface anatomy of a cadaver, if you want to mark the axillary artery, you actually take a point on the middle of the clavicle. Okay, so on the lower border of the clavicle, you take a point on the lower border of the clavicle, and then you take a point on the lateral wall of the axilla. So you are able to see the axilla is actually projected for you with all the walls. So this will be the lateral wall, floor, medial wall and apex. So along the lateral wall of the axilla, at the junction of the anterior 2/3 and posterior 1/3, at the junction of anterior 2/3 and posterior 1/3, you just keep a point. So you connect the first point and then you connect the second point with a curved line, and that represents the axillary artery on the surface. So this is done by a curved line while the arm is actually hanging by the side. Now if at all, if the arm is actually abducted 90 degrees, then actually you connect these 2 points by a straight line instead of a curved line. Okay, so that is about the surface marking of the axillary artery. Next structure is what you are able to see here is the brachial artery. So again, the brachial artery is very commonly asked as in the surface anatomy, your practical examinations. You know very well the importance of brachial artery. It is mainly for recording the blood pressure. So it is actually connected first by a point where the axillary artery has ended. Okay, so which means a point on the anterior 2/3 and the posterior 1/3 of the lateral wall of the axilla on the upper part. Then what happens is the second point where actually you should keep in the cubital fossa. You come to the cubital fossa and below the belt of the elbow, 1 centimeter just exactly below the elbow bend, you try to palpate the tendon of biceps and immediately medial to it you keep a point that will exactly correspond to the neck of the radius. So you connect the first point and you connect the second point, and that 2 points if you connect will actually give the surface projection of the brachial artery. Okay. Then what happens is at the neck again the brachial artery will terminate into radial and ulnar artery. It will terminate into radial and ulnar artery. So a point on the lower part, termination of the axillary artery, and 1 centimeter below the bend of the elbow in the cubital fossa, you connect these 2 points, and that will give your surface marking for the brachial artery. The next structure which you are able to see, you can appreciate in your own body or in your own limb, the anatomical snuff box. So it is actually again a depression or hollow which is present on the thumb on the lateral side of the wrist. So a depression or hollow which is seen on the thumb on the lateral side of the wrist. The boundaries, again the tendons, you will be able to identify only if you extend your thumb. You nicely extend your thumb, then naturally all the tendons you can see prominently, especially this tendon what you are able to see here in front. Actually this is the front, abductor pollicis longus and extensor pollicis brevis. Okay, this is abductor pollicis longus and extensor pollicis brevis. Don't think this is back. In anatomical position only this comes to the front. Okay, we all are actually discussing based on the anatomical position, all the structures. And posteriorly this tendon very well you can appreciate. Only thing, if you are not very much obese, then if you extend your thumb, this tendon you can easily appreciate, that is posteriorly or behind it is bounded by the extensor pollicis longus. Okay. So in anatomical snuff box, why it is important? It is crossed by the radial artery. So it is actually crossed by the radial artery. You can also just slightly, if you compress against the wrist, the radial pulse also you will be able to record. Okay. So arterial pulse rate you can actually just record here in the anatomical snuff box. And one more structure which is passing superficially is your cephalic vein. Along the roof of the anatomical snuff box, it will actually be crossed by the cephalic vein and your superficial branch of radial nerve. Okay. But mainly we actually consider the anatomical snuff box for the radial artery, and second one is the cephalic vein. It is just crossing the roof, the cephalic vein. The next 2 arches, superficial palmar arch and the deep palmar arch. So here you are able to see the superficial palmar arch. Now what are the points? First of all, you have to mark on the pisiform bone. Okay. So scaphoid, lunate, triquetral and pisiform. So one point on the pisiform, then another point you keep it below the pisiform. What you will have? The hamate. So a point on the hook of the hamate. So one on the pisiform, one on the hook of the hamate, and then on the palm, just opposite the level of the lower border of extended thumb. Okay, this will be your lower border of the thumb. You just extend your thumb, lower border of extended thumb, you keep a point, and then at the middle of thenar eminence, under the middle of the thenar eminence. So 4 points. Okay. First point pisiform, second point hook of hamate, third point a line, horizontal line drawn in the palm opposite the level of the lower border of extended thumb, and then a point on the middle of the thenar eminence. You connect all these 4 points and there you will get the surface marking of the superficial palmar arch. Next structure for the surface marking which we are considering is the deep palmar arch. Okay, so the deep palmar arch, it definitely lies at a higher level. It is actually at a higher level than the superficial palmar arch. First, on the hook of Hammett, a first point on the hook of Hammett, then you draw a 4 centimeter line. You are able to see, draw a line of 4 centimeters laterally from the first point. Then it should be 1.25 centimeters above the superficial palmar arch. Okay, or very simple, you need not draw the superficial palmar arch also. You just take the lower border of the extended thumb, that region opposite the palm, you come to the palm opposite to that region, and 1.25 centimeters above that you draw a horizontal line, and you connect from the hook of Hammett and then this horizontal line which you have drawn, and that gives the surface projection for the deep palmar arch. Okay, so we have finished mostly the axillary artery, brachial artery, the superficial palmar arch, and then the deep palmar arch. Okay. Nerves. So mainly the nerves which you are seeing is the brachial nerve, median nerve, and the ulnar nerve. Now first let us see the ulnar nerve. In the forearm, we are going to actually discuss the ulnar nerve surface marking. Behind the medial epicondyle, nerve is also ulnaris. Okay, the nerve is directly exposed and very superficial. So first point you keep behind the medial epicondyle. Okay, on the dorsal aspect of the medial epicondyle, and then you keep a point on the pisiform bone on the lateral side. Don't come to the medial side. Pisiform will be the most medial, so you keep on the lateral side of the pisiform bone. So that will give your surface marking for the ulnar nerve. You draw a vertical line connecting these 2 points. If you connect these 2 points with the vertical line, then naturally what you get is the ulnar nerve surface marking in the forearm. Then median nerve. So here you are able to see the median nerve in the forearm. So a point where the axillary artery terminated. So lateral wall of the axilla, junction of anterior 2/3 and posterior 1/3. You keep a point there, 1 centimeter below the bend of the elbow, medial to the biceps. Again medial to the biceps. That is the location of the median nerve in the cubital fossa. So tendon of biceps you can identify very nicely if you just extend your elbow, then you can see a tendon, you can palpate the tendon, and immediately medial to the tendon you can actually put a marking over there with a chalk piece on the cadaver, and then a point in the wrist. Okay, a point on the wrist. It should be between the palmaris longus and the flexor carpi radialis. So palmaris longus and flexor carpi radialis. So these 2 tendons you can again easily locate if you bend your wrist. Okay, if you actually extend your wrist, then you will be able to palpate these tendons. Don't flex your wrist. You can extend and then you can see the tendons actually projecting. So one point at the termination of axillary artery, one point actually in the cubital fossa medial to the tendon of biceps, another point in the wrist between your palmar is longest tendon and flexor carpi radialis. It is actually there the nerve comes superficial. You connect these 3 points and then it gives the surface projection of the median nerve. Radial nerve in the arm, especially in the spiral groove. Radial nerve in the spiral groove. So again, this is your lateral wall of the axilla, same at the anterior 2/3 and posterior 1/3. See, actually that point is actually serving as a surface marking for 3 structures. For the axillary artery termination, we have seen that. For the brachial artery beginning also, we have seen that same point. For the median nerve marking also, we have actually seen that same point. Okay. And now for the radial nerve also, you mark on the lateral wall, and then on the posterior aspect of the arm, you should actually on the posterior aspect of the arm, a point between the deltoid insertion and lateral epicondyle of the humerus. Between these two, you take a midpoint. So deltoid will form the rounded contour of the shoulder. Okay, and then you can palpate the deltoid muscle if you slightly abduct your arm. And then what happens is you take the midpoint between where the deltoid ends and the lateral epicondyle, which is a bony projection. You take a midpoint of it. You connect the first point and the second point by an oblique line. Okay, so you join the first and second point by an oblique line, and that will give you the surface marking of radial nerve. So radial nerve in the arm or radial nerve in the spiral groove. Okay, so most commonly it is injured, radial nerve in the spiral groove, especially we call it as Saturday night palsy. Next, ulnar nerve in the hand. Now, why ulnar nerve in the hand is very important? That is because the ulnar nerve in the hand only supplies most of the muscles, intrinsic muscles of the hand. Very easy to actually mark the surface marking of ulnar nerve deep branch. It is actually the deep branch of ulnar nerve. You first, what you do is mark the deep palmar arch. So how did we mark the deep palmar arch? Hook of hamate, and then a 4 centimeter line which should be 1.25 centimeters above the superficial palmar arch, which will correspond to the lower border of extended thumb. That is your deep palmar arch, we have seen already. Now what you do is just along the concavity of the deep palmar arch. Okay, so very close to the deep palmar arch, you again draw a concave line, curved line that will represent your ulnar nerve. Okay, so along the concavity of the deep palmar arch, you just draw the ulnar nerve. That gives the surface marking of ulnar nerve, but don't draw it very up till the most lateral border, because this nerve ends at the adductor pollicis muscle itself. So don't just completely travel across, draw across the thenar eminence. You should stop just before that. Okay, so deep branch of ulnar nerve is the surface marking. Next is axillary nerve. Again, axillary nerve, why it is important? So why actually in surface marking, which is one of the preferred question in the surface marking in the upper limb, is because surgical neck of humerus. Fractures of surgical neck of humerus, then axillary nerve is involved. So paralysis of deltoid muscle. Okay, so 2 centimeters above a midpoint of line joining the tip of acromion process and insertion of deltoid. Okay, so what you do is you take the midpoint of the acromion and the deltoid. Then from this midpoint 2 centimeters above, okay, 2 centimeters above, if you take, draw a horizontal line through this point. Okay, so this will be the midpoint of your acromion and the deltoid insertion. 2 centimeters from this midpoint, if you just draw, it is actually the surface projection of the axillary nerve corresponding to the surgical neck of humerus. Next is Flexor Retinaculum. So it is marked by 4 points, 2 lines which are 2 centimeters apart. One is a point on the pisiform bone, another point actually on the tubercle of scaphoid. So you draw a line with the concavity facing downwards. You draw a curved line with the curve facing downwards. Point on the pisiform, a point on the tubercle of the scaphoid. The next, you keep a point on the hook of hamate, and then you keep a point on the crest of trapezium. Then what happens? You draw a curved line with the concavity downwards or convexity upwards. So 4 points. Or either way, you can mark the points first medially, the pisiform and hook of hamate. Laterally, it is actually the tubercle of scaphoid and the crest of trapezium. So the above one you join with a curved line. The curve should be facing downwards. The other one also curved line, the curve facing upwards. That will actually reflect your flexor retinaculum. The next surface marking which you are able to see here is the extensor retinaculum. A point on the lower part of the anterior border of radius. Then 2 centimeters above the first point you keep another point. Okay, first you mark lower part of anterior border of radius and you mark a point 2 centimeters above the first point. Then you mark styloid process of ulna, a point on the tip of styloid process of ulna, and 2 centimeters below the third point. Okay, 2 centimeters below the third point. Are you able to understand? So now what you should do is you should join the second and the third. Then you should join the first and the fourth point. First point is lower part of anterior border of radius, and fourth point will be 2 centimeters below the styloid process of ulna. This is 2 centimeters above the radius and this is styloid process of ulna. So you draw these 2 lines. So a 2 centimeter gap should be there between these 2 lines and you should draw it obliquely. And that is actually representing your extensor retinaculum. Surface marking for the extensor retinaculum. So I have discussed about few aspects of the surface marking of the upper limb. We have seen some nerves, radial nerve in the radial groove, ulnar nerve in the hand as well as in the forearm, then medial nerve in the arm and forearm. Then we have seen about the axillary nerve. Arteries, we have seen axillary artery, then brachial artery, superficial and deep palmar arch. Okay. Then we have also discussed about the flexor retinaculum and the extensor retinaculum. So now we are moving on to the lower limb. The first structure which we will be discussing is the femoral artery and the femoral vein. So it is very easy to actually mark the surface anatomy of the femoral artery. Mid-inguinal point. You keep a point on the mid-inguinal region. So mid-inguinal region is from the anterior superior iliac spine to the pubic symphysis. Just middle of this point will give your mid-inguinal point. Then you keep another point on the adductor tubercle. You keep another point on the adductor tubercle, which is immediately above the medial epicondyle of the femur. Okay. So a second point on the adductor tubercle. Then you connect these 2 points, and the upper 2/3 of this will represent the femoral artery. Okay. So the upper 2/3 of this will actually represent the femoral artery. Midinguinal point to adductor tubercle, but you should not completely drop the adductor tubercle. The upper 2/3 of this line you can just draw, and remaining 1/3 you can just erase it off. Femoral vein is just medial to the midinguinal point. You draw a line, 1 centimeter thick line in the upper part of the femoral artery. So femoral artery surface marking, upper part. Then what you should do is, behind this marking you should draw for the femoral vein in the lower part, because it passes posteriorly. And then you should again mark it on the lateral side, lower part of the femoral artery. You should mark it laterally. So you divide the femoral artery into 3 parts. In the upper 1/3 you put the marking medially, middle 1/3 behind, and lower 1/3 laterally. So that will give the marking of the surface marking of the femoral vein. So medial to this line, I have actually given only the upper part of the femoral vein, but then you can continue it to even its course in the adductor canal. So femoral artery is again very important, and femoral vein, because for so many procedures, clinical procedures, if you want to put a catheter, and for so many other procedures, the femoral artery is most preferred. So knowing the surface marking of femoral artery is essential. Next, we'll be discussing about the sciatic nerve. This is actually the sciatic nerve. First, you take a midpoint between the posterior superior iliac spine and the ischial tuberosity. From the posterior superior iliac spine and the ischial tuberosity, you take a midpoint. Then you take a midpoint between the ischial tuberosity and greater trochanter. So you actually take ischial tuberosity and greater trochanter. The midpoint of this line, you make a point here. So first point is the middle of anterior posterior superior iliac spine and ischial tuberosity. The second is actually the midpoint of a line joining the ischial tuberosity and the greater trochanter. The first point and second point you connect it by a line, then naturally what you get is the sciatic nerve. So two more nerves are also they are showing here. Can you identify what is this nerve? That should be your superior gluteal nerve, and this should be your pudendal nerve. Okay. So first point, midpoint between the ischial tuberosity and the posterior superior iliac spine. Next one between the ischial tuberosity and the greater trochanter of femur. Then upper angle of popliteal fossa. Third point. So first and second point you connect it by a curved line. From the second to third point you actually connect by a vertical line. So that gives the surface marking of the sciatic nerve. Popliteal artery. So popliteal fossa is actually a hollow depression on the back of knee, and it is more appreciated when you flex your knee. So a point on the junction of the middle and lower 1/3. Actually what you are seeing in this picture is a junction, a starting point of the middle and lower 1/3 of the thigh, just medial to the midline. Okay, 2.5 centimeters medial to the midline on the back of the thigh, you put a point. Second point in the middle of the knee, the hollow depression in the middle of the knee, you draw a point. You connect these two lines, and that will give the surface marking of the popliteal artery. Okay, so mostly in the middle you can palpate or site for palpation of the popliteal artery. Third point, actually you should keep at the level of tibial tuberosity. From there it is going to divide into anterior and posterior tibial artery. So 1 point, junction of the middle and lower third of the thigh, 2.5 centimeters medial to the midline. Second point in the middle of the knee. Third point at the level of tibial tuberosity. Tibial tuberosity will be anterior, just behind the tibial tuberosity. Mark a point and draw a line connecting these 3 points, and that will give the popliteal artery surface marking. The next very important one is the Dorsalis Pedis artery. Midpoint between the two malleoli, the medial malleolus and the lateral malleolus. So you take a midpoint between the two malleolus. Proximal part of the interdigital space, proximal end of the interdigital space, or you can call it as intermetatarsal space. Okay, between these two this is the first metatarsal, you can palpate very well. Second one, between these two intermetatarsal space, proximal end of the space, you connect it by a line, and that gives the surface marking of the Dorsalis Pedis artery. So again, this is one of the important arteries where you can palpate for the peripheral arterial pulse. So that is why again you should know the surface marking of the Dorsalis Pedis artery. So join these 2 points for the marking the Dorsalis Pedis artery. Dorsal venous arch. So you put a first point on the midway between the ankle and the metatarsophalangeal joint. So that is the region of the dorsum of it you should select. Ankle joint, and this is your metatarsophalangeal joint. So you take a midpoint between these two. Medial border of the foot. At this level, you put a medial border of the foot, a point, and then another point on the lateral border of the foot. You connect these 2 points by a curved line with the convexity facing downwards. So convexity, or it is bending downwards. That will give the surface marking for the dorsal venous arch. Okay. Great saphenous vein, a point on the dorsum of foot and the medial end of the dorsal venous arch. Just we have seen the last slide only where you mark. So medial end of the dorsal venous arch along the medial border of the foot. Then the next point will be in front of the medial malleolus. A point on the medial malleolus. Then the third point will be on the medial border of tibia. So at the junction of the upper 2/3 and lower 1/3 anterior border of tibia. And then what happens? A point on the adductor tubercle. Medial part of the dorsal venous arch, medial end, in front of the medial malleolus, anterior border of the tibia, medial border of tibia at the junction of upper 2/3 and lower 1/3, point on the adductor tubercle. You also can mark a point here, hand's breadth behind the knee. Okay, behind the knee. Here also you can mark one additional point. Then finally you have to make a point just below the center of saphenous opening. If you connect all these points, you get the surface marking for the great saphenous vein. Now again, saphenous opening itself again is an important point for surface marking. How will you mark saphenous opening? 4 centimeters below and lateral to the pubic tubercle. 4 centimeters below and lateral to the pubic tubercle. You mark a point that is on the medial side of the thigh, that gives the surface marking or surface projection for the saphenous opening. Okay. So this is about the great saphenous vein. Next, coming to the small saphenous vein. So lateral end of dorsal venous arch, behind the lateral malleolus. Point on the lateral end of dorsal venous arch, a point behind the lateral malleolus, a point along the lateral border of tendocalcaneum. Here you are able to see the prominence of the tendocalcaneus. So just lateral to the tendocalcaneus, above the lateral malleolus. Then a point on the center of popliteal fossa. 4 points. Lateral end of dorsal venous arch, lateral malleolus, behind the lateral malleolus, immediately above the lateral malleolus, lateral to the tendocalcaneus, and a point on the center of popliteal fossa. So that gives the surface projection of the small saphenous vein. So I have discussed about the surface marking with respect to lower limb, mainly two veins, great and small saphenous vein, two arteries, femoral artery and dorsalis pedis artery, then sciatic nerve. Okay, I have actually discussed about the sciatic nerve, femoral artery, along with femoral artery, even the femoral vein. Now just I have enumerated some important essays and short notes on upper limb as well as the lower limb. Now, when you are going to actually going to prepare for your exams with respect to the upper limb and lower limb, these questions what I am giving is only a general guideline or value. You can just take it as a general guideline, so which will help you to prepare in the exams. These are most commonly asked questions which appear in the university examinations, but this cannot be taken as authoritative that definitely no questions will come outside this or this question should definitely come. This gives a general idea, and about 75% of the upper limb and lower limb I have covered here. Sometimes what happens is definitely questions come out of this, and my sincere advice is, especially with respect to the medical profession, you should have a general idea of all the topics. Okay, it is not, you cannot excel, or you cannot excel in your exams by just simply memorizing some few topics. You just by heart it or memorize and you expect that to come in the exams. We should understand the concepts, and then what happens is you should be a jack of all instead of being a king of only one thing, because you will be taking a very great risk in your examinations. Anything suddenly they can ask. For example, fibrous flexor sheath, if they ask. So definitely the day before the exam you would not have time to prepare the whole thing. Paper 1 or paper 2 you have to discuss about upper limb, lower limb, abdomen, pelvis, perineum will be appearing in one paper, and the remaining regions will appear in the second paper. And then you also have its associated embryology, histology, then genetics. Okay. So suddenly some questions, some surprise questions might arise. Fibrous flexor sheath, as I told you, one of the question, or sometimes a very important question you would have not have time to prepare. So what you should do is, so that is why instead of by hearting word by word from any textbook, you should have a general idea. Now for example, let us take brachial artery. If the brachial artery is asked, what is expected from you is you should write about it is a continuation of which artery, then it terminates into what two arteries, then a fair idea of the branches. So what are all the branches and how it supplies, and the applied anatomy. Okay, so don't give much stress, for example in case of brachial artery, to the relations like it passes between this and it comes out like that and all those things. Same way, if they ask about the brachial artery relations also, only thing a little bit of presence of mind. For example, cubital fossa. So you would have read cubital fossa very nicely. Brachial artery is a content of cubital fossa and you know where it is present. It is present between the tendon of biceps and the median nerve. So it is between these two. So immediately that should strike your mind, cubital fossa every day. That sentence of brachial artery, what is there, you can take and write for brachial artery. If at all surprisingly, if the brachial artery appears and you have not prepared. So this, I am just giving a general example, keeping as brachial artery as an example. So like that, any question, wrist joint, suppose if they ask, so you cannot simply omit the wrist joint. That is, will be a very great. So you should write about the type, what type of joint is wrist joint. It is actually cellular type or ellipsoid type. And then what are the bones forming type, articulating surfaces, fair idea about the articulating surfaces. Then capsular ligament is definitely any joint will have a capsule, synovial joint. So you should write one of the ligament is capsular ligament. And attachments of the capsule is always to the peripheral margins of the articulating surface, mostly. Okay. But there are minor variations. In shoulder joint, it may dip a little bit 1 centimeter below. In the hip joint, it crosses apart from the head and actually goes to the intertrochanteric line or something like that. There are minor variations. Okay. Then what happens is you can write about ligaments. Suppose it is very difficult to remember the ligaments of wrist joint. Movements, definitely your wrist movements you should be able to remember. So you simply move your wrist, flexion, extension, and it also does adduction and abduction. So that means again two planes. So two planes you are moving, so it is a biaxial joint. So flexion, so many flexor muscles you would have read, so you can write about that, but don't write. Again, little bit of concentration. If you see, the long flexors are going to the fingers, so naturally you cannot write about the long flexors. Flexor carpi ulnaris and radialis you can write flexion. So mainly you should write something correct, you should not write nonsense. That is main important, because you are exposing yourself that you don't know the subject. Same way extension you can write about the brachioradialis. Brachioradialis is more of a, not an extensor, but extensor carpi radialis longus and extensor carpi radialis brevis. All those things you can actually write for the extension. So some of the arteries, some of the questions which I have discussed here is the brachial plexus, and then axilla is again very important essay question. Mammary gland, especially you should concentrate on the lymphatic drainage. Then shoulder joint, so articulating surfaces, ligaments, relations. Then the essays, axillary artery, brachial artery, radial nerve. Then radial nerve joints, they are very important for their movement, pronation and supination movement. Then again, first carpo-metacarpal joint, unique to man because of the movement of the thumb. Then facial spaces is important for its clinical significance. So if the spaces are infected, how actually you drain these, where the infections can spread from one space to another space, from mid palmar space or inner space or palm space of fingers. Okay. So some of the most important essays of the upper limb I have enumerated. So these are the short notes, axillary lymph nodes, Klumpke's paralysis. With respect to Klumpke's paralysis, now you might ask, I have not actually discussed much about any questions on clinical anatomy. Clinical anatomy, it comes as a part of your essay. So anything about brachial plexus, definitely you should write about clinical anatomy. Brachial artery, you should write about its clinical anatomy. Radial nerve, you should write about its clinical anatomy. So it is actually understood without saying. Intermuscular spaces, your quadrangular, triangular spaces. Anastomosis around scapula. See, rotator cuff is again a part of shoulder joint, so it might come as a short nodes. Cubital fossa. Then most of the short nodes are from the palm region. Palmar aponeurosis, flexor retinaculum, extensor retinaculum, superficial and deep palmar arch, lumbricals and interosseous, cutaneous innervation of hand, ulnar nerve in hand. So most of these are actually from the palm. You get a lot of short nodes from the palm. Dorsal digital expansion. So these are all the palm structures mostly. So some of the short nodes on lower limb also I have actually enumerated for you. The next essays on lower limb, mainly femoral triangle is very important. Front of thigh, type of femoral hernia. What are its complications? You should know. Then hip joint, ball and socket. So tight articulating surface, ligaments of hip joint. Then femoral artery, it is very extensive because we have to write also about the profunda femoris artery, but sometimes they ask femoral artery, as I told you, for its clinical applications. Then sciatic nerve. The knee joint. See, knee joint is a very vast joint. I have described about this knee joint in 2 classes, 2 hours. But since most of the essay questions in the university, they come as a structured question. So they don't ask everything. They might ask simply type. They might restrict to 1 or 2 ligaments they might name, and then nerve supply and movements. Okay, not the whole. You cannot nowadays they don't ask about knee joint, describe knee joint in detail or describe femoral artery in detail. It is a structured question. So that is what you should again see how it is structured, what are the subparts of an essay, and you write to that point so that you will be able to save your time. Because for example, hip joint, if they ask, you simply see that word hip joint, you start writing for 4 to 5 pages about hip joint, where you will be wasting around half an hour in one essay. Then definitely you won't be able to complete the whole paper in your examination. See what is asked, to the point you write and see the marks allotted for each. Type means 1 mark. If they have allotted, simply write what is that type. Variety, what is the variety. Movements, if they ask what is the amount, you simply write the name of the movements and the prime muscles producing that movement. Flexion of hip joint, you put iliacus and psoas major. So like that. Then venous drainage of lower limb, again is very important. Arches of foot is a very important topic, and again subtalar joint is asked for its inversion and eversion movements. So short notes on lower limb is again adductor canal. Adductor canal sometimes can also occur as a essay question. So again here I would like to stress that an essay concept femoral triangle again can appear in a short note. So that means again you should not write so elaborately, just mention the boundaries and then just mention the contents and what forms the roof and floor. You need not elaborately describe about how the contents are actually present with its the relations and all those things. Femoral sheath, then gluteal, all 3 muscles are important. Gluteus maximus, medius and minimus for its action and clinical anatomy. Trendelenburg sign. Profunda femoris, cruciate and trochanteric anastomosis, menisci of knee joint, medial and lateral menisci. Sometimes they might ask intracapsular extrasynovial structures of knee. Then you have to write about this menisci and you have to also write about the cruciate ligament of the knee joint. Then locking and unlocking, inversion and eversion of foot, popliteal fossa, boundaries and contents, lymph nodes. Usually students tend to actually ignore the lymph nodes because lymph nodes play a very much vital part in the spread of infection. So that is why always have a fair idea of the lymph nodes. Then about the quadriceps tendon, what are the 4 muscles contributing for it and how it is getting attached and what is its action. iliotibial tract, triceps surae, gastrocnemius soleus, tendocalcaneus, triceps surae. So if you prepare venous drainage, again from that long and short saphenous vein can be asked. If you prepare arches of foot, any one of that medial longitudinal arch can be asked. Then of course, not to be missed, your dorsalis pedis artery, plantar aponeurosis, sole of the foot. Any individual muscles, usually it is not asked, they can ask your plantar aponeurosis. Again, you can write very well about the plantar aponeurosis if you have read about the arches of foot. Then deep peroneal nerve, anastomosis around the knee joint, spring ligament. Again, we have discussed about the spring ligament in the arches of foot, what is its important. Deltoid ligament is a medial ligament of ankle joint, cutaneous innervation of foot and extensor retinacula. Okay, so with this we have completed the limbs. We will start with a new region very shortly. So thank you very much for your patient listening.